I'm Joe Graydon.
And I'm Terry Graydon. Welcome to this podcast of the People's Pharmacy.
You can find previous podcasts and more information on a range of health topics at peoplespharmacy.com.
What's it like to practice medicine in the middle of a pandemic? Dr. Danielle Ofri is a doctor at Bellevue Hospital in New York City. This is the People's Pharmacy with Terry and Joe Graydon.
Dr. Ofri is the author of When We Do Harm, A Doctor Confronts Medical Error. How common are medical mistakes? Dr. Ofri provides an in-depth exploration of this challenging topic.
It can be hard for a healthcare professional to speak up, even if they witness a potential mistake. When Dr. Ofri was a medical student, she said nothing about a needle stick during surgery, even though she could have been exposed to HIV as a result.
Coming up on the People's Pharmacy, medical errors and how to avoid them. In the People's Pharmacy health headlines, there's growing evidence that people without symptoms are able to spread the coronavirus infection. New data from several sources suggests that a significant proportion of people infected with SARS-CoV-2, the virus that causes COVID-19, are asymptomatic when tested. The aircraft carrier Theodore Roosevelt had nearly 5,000 sailors on board. The Navy tested all of them and found that more than 600 carried the virus. 60% of them reported no fever, fatigue, cough, or other symptoms. Some experts now believe that more than 50% of those who test positive for the virus have no symptoms but can still spread the infection.
Additional research is uncovering new ways that SARS-CoV-2 virus spreads. A research letter in Emerging Infectious Diseases describes how one diner in a restaurant in China infected 9 other people. She felt well when she lunched with her family, but later came down with a cough and a fever. She tested positive for COVID-19, so when 4 other members of her family became infected, it was not a surprise. The news in this report, however, is that the other 5 individuals were strangers to her at adjacent tables in the restaurant. The tables all had air from the same air conditioner blowing over them. Because the coronavirus was not yet discovered in Guangzhou at the time, the restaurant was the most likely source of infection. However, 73 other people who had lunch in the same restaurant but were not sitting in the path of the same air conditioner did not get sick. This research suggests that airborne particles are an important source of infection. As the U.S. begins to reopen, restaurants and workplaces will need to keep this type of airborne viral spread in mind.
Not surprisingly, the pandemic that has many people trapped in their homes and others putting their lives on the line as they do essential work has affected mental health as well as physical health. Express Scripts, a pharmacy benefit manager, says that prescriptions for sleeping pills, anxiety medicines, and antidepressants all increased significantly from February to March. Scripts for anti-anxiety medicines went up 34% during that time. About 3/4 of the prescriptions for mental health medications were new rather than refills, suggesting that more people than ever are dealing with anxiety, insomnia, and depression.
Tens of millions of people take blood pressure medications called ACE inhibitors or ARBs, angiotensin receptor blockers. These drugs are sold under names such as lisinopril and losartan. Because the SARS-CoV-2 virus uses the ACE2 receptor to enter cells, some scientists have asked whether ACE inhibitors or ARBs might affect the course of the infection. An answer has come from researchers in Wuhan, China. They looked at records of patients hospitalized with COVID-19. Those taking ARBs or ACE inhibitors had no difference in the disease progression and risk of death during hospitalization. People taking such medication for hypertension should not change their regimens.
At this time, we need pharmaceutical quality more than ever. But A new announcement from the FDA is disturbing. The agency recently issued a nationwide recall of the antibiotic tetracycline made by Avet Pharmaceuticals and distributed under the Heritage Pharmaceuticals label. Tetracycline is prescribed for a range of infections, including pneumonia. The problem with the Heritage tetracycline is poor dissolution. According to the FDA, this can lead to treatment failures. If there's not enough tetracycline in the body to fight the infection, this could result in rapid progression of the infection and death.
Danish researchers have conducted 2 studies regarding testicular function. In one, a healthful diet with lots of vegetables and fish was better for sperm quality than a typical Western diet, high in meat and processed carbs. In the other, men taking fish oil supplements had higher sperm counts and higher free testosterone. And that's the health news from the People's Pharmacy this week. Welcome to the People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon. COVID-19 has put an enormous strain on our healthcare system. Hospitals and the people who staff them have been overwhelmed, especially in New York City. It's been an epicenter of infection. Although the number of people hospitalized is now beginning to come down, it's still high. To get some sense of what it's like for healthcare professionals, we turn to a doctor on the front lines.
Our guest is Dr. Danielle Ofri. She's a physician at Bellevue Hospital and a clinical professor of medicine at New York University School of Medicine. Dr. Ofri is editor-in-chief of the Bellevue Literary Review and author of several acclaimed books, including What Doctors Feel. Her latest book is When We Do Harm, A Doctor Confronts Medical Error.
Welcome back to the People's Pharmacy. Dr. Danielle Ofri.
It's so nice to be here again.
Dr. Ofri, I understand that you work at Bellevue Hospital, right in the epicenter of all of the COVID-19. I am a little reluctant to say excitement, but it must be intense right now. Can you tell us a little bit about what it's like in general for you and your colleagues and how you're handling this?
Well, intense is the right word. I mean, before it all started, we kind of joked, boy, if coronavirus is coming to New York or to the U.S., it's going to come to Bellevue in the same way that Ebola did several years back. And indeed it did. But in the course of 3 or 4 weeks, we went from 1 patient to 250 patients with COVID quite quickly, and with more than 100 in the intensive care unit. So it's been very intense. The patients are extremely sick, and we're so filled that we're taking care of ICU level patients often on the regular floor. So it's much more intense than typical medical wards are. And right now it feels as though we've hit I'll say this cautiously, we may have hit the peak, or really the plateau, because it's not one peak, and the plateau is going to be long. And I think the experience in Washington has suggested that the plateau takes a while because these patients stay sick for a long time, and much longer than patients who normally end up intubated from pulmonary issues. They may take 2 or 3 weeks in the ICU instead of 1 week. So we expect this plateau to last some time. So although there's sort of glimmers of hope in the outer world, we haven't really felt that yet. I mean, today I was up on the wards and there were 4 codes in an hour, just one after another of, respiratory arrest. So there's still a lot happening, and we don't yet feel the easing off. We're no longer increasing every day. I mean, that was very intense when every single day the numbers were higher and higher. We just kept adding more and more doctors and nurses, and who knew where it was going to end. I think we finally are now at a steady state, but at a very difficult steady state. And it will be some time, I think weeks, before we start to feel some easing up.
Something like a marathon rather than a sprint.
Oh my gosh, but the beginning of the marathon was an ongoing sprint as we just keeping up, opening more beds, bringing on more doctors, bringing in everyone and their uncle to come work in the hospital. That was exhausting. Now it's the level marathon, but still feels very sprint-like.
Yes, I can only imagine. It's got to be really, really tough. And I can only imagine that most of the people who show up at your hospital are feeling extremely anxious.
Oh my gosh, the anxieties. Well, most people who come to the hospital now, in the beginning, there was a mix. People who weren't so sick came to. Now, anyone who's not extremely sick now stays home. Nobody wants to come to the hospital. So the only patients we get now are very sick, and they're usually very short of breath. So they're already anxious just from feeling breathless. But they're also terrified, and understandably so. And treating anxiety has become a big part of the medical treatment. Anxiety of the patient, of their family, and of course, the healthcare workers as well. It's a very, very anxious time. Very sadly, we've had 2 nurses die in our hospital in these last 2 days.
And I've been wondering what it's like for the healthcare team. I mean, there have been a lot of healthcare workers who have come down with COVID-19, and far too many have died. What about your anxiety level?
Right. It is very hard. I think the hardest thing for most people I talk to, most of my colleagues, is the balance of their families. You know, if you live alone, it's a little bit easier. You just come home yourself and you shower. But if you come home and you've got family or children, it's so hard because you feel a little contaminated. And everyone has their own private ritual of stripping off their clothes at the door and diving in the shower. It's very hard. You know, my family's home and they don't go out, but I'm the only person who comes and goes. Their only chance of exposure at this point is from me. And if one of them were to get it, I would feel terrible. And so for many people, that's so stressful. And a lot of healthcare workers have moved out of their homes, staying in hotels to protect their families. And so now they have the stress of not being near their families during this time. So that's very hard.
Yes, it's got to be just really incredibly stressful.
Well, we're here to talk today about your book, and it's really quite extraordinary. It's almost hard to imagine, quite honestly, how you find time in your incredibly busy schedule to be able to write as prolifically as you do, and for the New York Times. But the new book is all about medical errors. And I guess the first question I have is, well, what are medical errors? What do we mean when we say medical errors?
That's a great question because we mean a lot of things, and often the term is used in many different ways. I think in the public mind, a medical error is when the surgeon cuts off the wrong leg or we give the wrong medication. And those are certainly errors, to be sure. But we've really broadened the definition of medical error to include the whole concept of patient safety, of adverse events, of things that go wrong that shouldn't have. So, for example, if someone gets a CAT scan and has a terrible reaction to the contrast dye and goes into renal failure, that might not have been an error per se in the traditional sense of the error, but it's certainly an adverse outcome on the patient that was not part of the original treatment plan. So I use the term to include the idea of adverse events of all kinds, of all the things that we don't wish to happen to patients, but that do anyway.
Dr. Ofri, in the first pages of When We Do Harm, your book, you describe a letter from or an email from your editor saying, is this really true? And you thinking, how could it possibly be true that medical errors are the 3rd leading cause of death in the United States? Tell us a little bit about that research that brought that statistic forward, and why was it so hard to believe?
So back in 2016, an article came out in the British Medical Journal, BMJ, looking at medical errors and concluding that medical errors were the 3rd leading cause of death. And this article made headlines all over the place, much like the 1999 Institute of Medicine report that claimed that between 40 and 90,000 Americans died every year of medical error, something equivalent to a jumbo jet and a half crashing every single day. So these were very vivid images and metaphors. And when my editor emailed me, she said, is this really true? And I'll say one thing about, being one of the only doctors in a publishing house full of English majors is you are on the receiving end of everyone's medical questions. So she was just asking me, and I thought, well, I don't really know. Is it really true? Because I feel like if it is true, then I should see it every single day in my practice, right? I mean, I work in a busy medical center in a city hospital, but I don't, or I don't feel like I do. So that got me wondering. That's probably how the book came to be. Well, gee, if medical error is the third leading cause of death, then we're blind to it. We're collectively not seeing in this epidemic, or it's not the third leading cause of death, and something about how we are interpreting data is incorrect. And it's important because we have to know where to focus our research efforts, our healthcare dollars, our ways that we change the whole healthcare system. We want to be putting it in the right place. We want to know if our data are correct or not.
What have you concluded? Are the data correct? Is medical error that big a problem?
Well, there's not going to be an easy, straightforward answer. And one of the reasons why not is that medical error, well, first of all, it is hard to define. And secondly, it's very hard to measure. Well, yes, so if someone, operates on the wrong side of the brain, that's a pretty easy one to identify. But, what happened if you had a bad reaction to a medication that you thought would have been the right thing to do, or you decided not to do a CAT scan when the patient has a cough and you waited 2 weeks, but they turn out to have a cancer? Is that an error or not? So it can be quite difficult to pinpoint what's actually an error. And the other thing is that this article and many of the medical error articles focus on errors that cause death. Now, that's very different than errors that don't cause death. In fact, it's probably a much larger pool of errors that don't cause death, but maybe cause strokes or cause falls or cause sacral decubiti, pressure ulcers. Those are important things to measure, but we miss those when we talk about errors that cause death. And then you might have a situation where, for example, a patient who's very sick with cirrhosis is given the wrong antibiotic and that patient dies. So there was a clear error and the patient also died. But did the error cause the death? I mean, the patient may very well have died of cirrhosis anyway. So there are many complicated reasons why the data are hard to interpret a yes or a no. So I don't think it's the third leading cause of death. It's probably a little lower down on there. And again, we won't be able to say an absolute number because it's so hard to measure. And we also don't have a denominator of the number of errors out of what pool of hospitalized patients, of outpatients, of the entire population. Very, very hard to make those numbers work. But the fact that it's lower doesn't mean that we should be ignoring it. It's still critically important to decrease the number of errors and adverse events and to improve patient safety overall.
You're listening to Dr. Danielle Ofri, author of When We Do Harm, A Doctor Confronts Medical Error. Dr. Ofri is a physician at Bellevue Hospital and editor-in-chief of the Bellevue Literary Review. She's also a clinical professor of medicine at NYU School of Medicine and a regular contributor to the New York Times.
After the break, we'll find out how hard it is to get a handle on medical errors.
In many situations, people have no incentive to speak out about errors and lots of reasons to keep quiet.
We'll learn how a checklist derived its power by deputizing nurses to speak up.
Does the electronic health record reduce errors, or does it create conditions for new types of problems?
We'll find out when a doctor who hears hoofbeats should look around for a zebra instead of a horse, and how patients can help.
You're listening to The People's Pharmacy with Joe and Terry Graydon.
The People's Pharmacy podcast is sponsored in part by Kaya Biotics. KAYA Biotics offers the first probiotics which are both certified organic and hypoallergenic.
All probiotics are produced in Germany under laboratory conditions with high-quality ingredients and under strict regulatory oversight.
The 3 available formulas are created for very specific purposes, such as strengthening the immune system, fighting yeast infections, and helping with weight loss.
To learn more about Kaya Biotics probiotics and the important topic of gut health, you can visit their website, KayaBiotics.com. That's KAYA Biotics.com. Use the discount code PEOPLE for $10 off your first purchase.
Welcome back to The People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon.
The People's Pharmacy is brought to you in part by Kaya Biotics, probiotic products made in Germany from certified organic ingredients. KAYA Biotics.com.
Also by Verizana, an analytical laboratory providing home health tests for hormones, gut health, and the microbiome. Online at verisana.com.
Today, we're talking about medical mistakes. This is a hard conversation to have in the middle of this pandemic. Doctors, nurses, and other healthcare workers are heroes who are putting their lives on the line every time they show up for work. This is especially true in a hot zone like New York City, where our guest cares for patients.
We're talking with Dr. Danielle Ofri, author of When We Do Harm, A Doctor Confronts Medical Error. Dr. Ofri is a physician at Bellevue Hospital and editor-in-chief of the Bellevue Literary Review. She's also a clinical professor of medicine at NYU School of Medicine and a regular contributor to the New York Times and Slate magazine. Her previous books include What Doctors Feel, as well as Singular Intimacies, Becoming a Doctor at Bellevue, in addition to Incidental Findings, Medicine in Translation, and What Patients Say, What Doctors Hear. Dr. Ofri's website is danielleofri.com. You could sign up for her monthly newsletter there.
Dr. Ofri, one of the challenges in trying to figure out, how many people are harmed, how many people die from medical errors. Dr. Marty McCary, who wrote the article that you mentioned in the BMJ, said, well, when it comes to death certificates, physicians rarely write died from a medical error. People die from heart attacks, people die from kidney failure, people die from all sorts of things, but medical errors are rarely listed. And it's not something the CDC keeps track of. I mean, they can tell you how many people die every year from cancer and heart attacks and strokes and emphysema, but they can't actually tell you how many people die from medical errors. Should we be keeping track?
Well, we should have some way of keeping track. And I think that Marty's idea of putting a checkbox on death certificate is really intriguing because we want to know death certificates are the way we measure causes of death, but would doctors actually check that? And I think in the United States, with the malpractice environment as we have it, I think is very unlikely. On the other hand, we could envision some kind of national registry where mistakes and errors and adverse outcomes could be submitted anonymously in a way to gather the data, even if we're not using it in terms of legal redress, because we do have to know how many are there, what kinds are there.
In fact, I think there's a statement that if you're not measuring something, you can't do anything about it. You can't change it.
It's absolutely true. And partly is when we measure, the only errors we tend to hear about are the big ones that cause death and blood clots and other large adverse events. But there's many more near misses out there. And a near miss just means the patient got lucky and wasn't harmed, but it's still an error. And those near misses are like the whole iceberg under the water. The much larger pool of potential errors or of errors with potential harms, that's where our research dollars should be going. But if we don't know what they are or where they are, we can't actually tackle the problem.
Now, Dr. Ofri, it's sometimes hard for people to speak up, hard for a nurse to say, wait a minute, doctor, hard for a resident to say, oops, I think I just did something wrong. You describe in your book a needle stick when you were, I assume, a resident or a medical student, and you just sort of stood there during the surgery without saying anything. Can you tell us about that, please?
I will never forget that night. I was a medical student late at night in some emergency something. I don't remember what it was. This is the height of the AIDS epidemic. And the surgeon's needle pricked my finger. And nobody said a word. Not the nurse, not the doctor, the surgeon. And I didn't know what to do. I looked around. Did anyone see it? Should I say something? And I was too frightened to speak up. And that I stood there with my fingers with a potentially pierced glove and hand, knee deep in blood at the height of the AIDS epidemic, and said nothing for the next hour tells you how powerful the hierarchy is and how hard it is to speak up. And it was devastating.
Well, because that could have been a life-threatening situation. You might have been exposed to HIV.
Oh, absolutely. And the fact that I couldn't speak up just speaks volumes. And that's just one tiny example. And I think it happens everywhere. And someone said, people die all the time because of hierarchy. And that's a terrible thing to accept, but it is true.
In fact, Dr. Ofri, you describe Dr. Peter Pronavost's checklist. It's a simple checklist. It's supposed to prevent infections of central lines, and I'll ask you to tell us what a central line is and why his checklist might prevent infections. But you say the real power of this checklist is not the boxes that get checked, but the fact that the nurses are now in charge. Tell us a little more, please.
So a central line is a large catheter that is put into one of the major veins, usually the jugular vein in the neck, or the subclavian vein under the collarbone, or the femoral vein in the crook of the thigh. And there's potential for infection, as with all of them, but because they're centrally placed, these infections are very concerning. And so Peter Pronavost established a very simple checklist. And I mean really simple, make sure you have the supplies, clean the site, put a clean wound on there. Nothing of rocket science.
And wash your hands, right?
And wash your hands, absolutely, like brushing your teeth. But the main part about why the checklist would work, what he calls the secret sauce, is the nurses were empowered to speak up. That is, if any one of the 5 steps were missing, the nurse was required to stop and say, well, you forgot step 2. And normally, nurses, not that they don't feel comfortable speaking up, but, there's 1,000 decisions every day. Which ones do you, expend your capital on? But now that the nurses could do this and they had their back was covered, the administration promised to back them up, they could. And infection rates dropped to 0.
And that was very impressive.
People thought that central line infections were just the cost of doing business. A certain percentage will get infected. Wasn't even considered an adverse event. It was just, like a side effect of a medication. Some people get it and you just go on in life with that. But he measured it and showed how you can really get it down next to 0.
Now, as I understand it, other people thought, well, all it takes is a checklist. Let's make a bunch of checklists. Didn't work so well, did it?
I think we love catchy solutions, especially if they, they're very low tech and they keep all those jumbo jets from crashing out of the sky. The media loved it and administrators loved it. The checklist, everything. And of course, government ministers would love it too. There's a famous experiment in Canada, in Ontario in 2010. The Minister of Health mandated that every hospital use the pre-surgical checklist, a similar checklist before you start operating, because that had worked in Tanzania, it worked in New Delhi. It should be a cakewalk in rule-abiding in Canada. And you know what? There was 100% compliance rate with the checklist and not one smidge of improvement. No matter how they sliced and diced the data, there was no improvement outcomes. And that's because if you insist on 100% compliance, that's what you get. People just check things off and hand it off because it's not about the checklist at all. It's all about the process of how you get it to work. Where are the supplies? Who's going to make sure we have enough? What are we going to measure? What do we do when we're short-staffed? All these details are very boring and very dry. But if you don't do them, any checklist or any intervention is doomed to fail.
Well, Dr. Ofri, this reminds me a little bit about the way in which doctors write prescriptions these days, because everything is now on the computer, the electronic health record. So if you start to write a prescription and the patient is taking maybe 2 or 3 other medications, perhaps it's a blood pressure pill, something for diabetes, and now you're adding maybe a sleeping pill or an anti-anxiety agent, and up comes a little warning, an alert, as it's called. And because there are so many of these alerts, it's a little bit like the cry wolf phenomenon. After a while, the health professional starts ignoring them, overriding them. And so even though there's this, I won't exactly call it a checklist, but a kind of a warning system, after a while, when something really important comes along, it may get missed. And the same thing can happen at the pharmacy. So sometimes I think the electronic health record, as wonderful as it may be, It can be a boomerang.
Oh, absolutely. And partly is what is the motivation behind these alerts? Ostensibly it's for patient safety, but a lot of it is about liability. If the electronic medical record or the hospital puts all these alerts up that the doctor evidently checked, well, then if something goes wrong, it's not their fault, it's the doctor's fault. But there are so many of them. I don't read them at all. It's impossible. I tried one day to read every single one. I was defeated by the first patient because so many are inane. Every time I get a pregnancy warning for a patient who's over 55, I want to pull my hair out. Or you get the over 65 prescribed with caution. Well, all my patients are over 65 and every medication gets that. And so you tune them out. But it makes me so angry because I know that buried in there are a couple of really important ones. I want to see those, but I can't because I'm just swamped with all the very middling to low level ones.
Exactly. And so they're hiding the stuff that really needs your attention. You also pointed out that implementation, it seems like a simple thing, but it can make a big difference. You describe coming in to see patients one day and discovering that overnight they had made some changes. IT had made some changes to the electronic health record. And all of a sudden, all of your patients that were normally coded number 41 for Spanish speaking, number 41 had all of a sudden turned into Serbian. Tell us more about that and how the electronic health record can actually get in your way.
Oh my gosh. Well, so we start to figure out the shortcuts. And so Spanish is the most spoken language in my clinic. So I know that the number for Spanish all the time. And they must have added a language and bumped everyone up. So now that same number was now Serbian. So everyone was speaking Serbian. And the same day, they moved up the past medical history, which used to be number 8. Now it was number 9, but I didn't realize that. And now number 8 was past obstetrical history, which I would automatically hit even on my male patients. And then you know what? I couldn't take it away. So I have a whole crew of male patients with their past obstetrical history attached onto the medical record. I didn't put much in there, but they all have an OB history now.
Oh, that's wild. Dr. Ofri, I'd like to switch gears a little bit now and talk a bit about diagnosis, because that is sort of the critical factor in making sure that the patient is treated correctly. If the diagnosis is wrong, then you're off the tracks before you even get very far down the road. So let's talk a little bit about how you had a personal experience with, I'll call it a misdiagnosis with Ms. Romero.
So Ms. Romero was a patient, it's not her real name, a patient of mine for a number of years who had a number of mild issues, thyroid, arthritis, nothing big. And she had an ill child that was usually occupied most of our visits. And then I went away for a year. I took a year off. And when I came back, the person who covered me informed me that the patient had an anemia that I had evidently missed or not worked up. And now, listen, anemia often or most often is, a mild thing. But in this case, it turned out the anemia was a cancer. And I had missed a blood cancer in her. And I was devastated. And I looked back at the chart, trying to figure out how I missed that. And I realized that, when you have a whole haystack, you might miss that one strand that turns out years later to be important. But I hadn't noticed, and I don't even know why I didn't notice it. It wasn't that significant for her. But it can happen even when we try to be very attentive to our patients' medical care.
Well, I've often heard the phrase, when you hear hoofbeats, think horses, not zebras. And that might have been the case in this situation with Ms. Romero. And I'm just wondering, sometimes, the circus is in town and there might be a zebra on the loose. How do we get doctors to be able to catch those zebras, especially when they don't have a lot of time these days?
When I think about it, for most of my patients, I have 15 minutes, maybe 20 minutes, and they have a lot of medical issues. And people have active diabetes and depression and obesity and heart disease. If there's a random small lab that's slightly out of line, you might not notice it because you really want to put your focus on the diabetes. So So one thing is I think we need more time, certainly for the complexity of today's patients. I mean, now that patients stay in the hospitals much shorter period of time, when they're home, they have much more serious illness to handle. So those office visits, can take a long time. So one of them is time. The second is to sort of train ourselves to kind of stop before we jump to a diagnosis and say, well, what else could it be? You're right. Most anemia is just, mild iron deficiency from menstruation, but what else could it be? And the third question we should ask, or the second question is there anything I can't afford to miss? What would be the one even rare thing that if I did miss it, it would be significant? Could it have been a blood clot or a cancer? So training ourselves to discipline ourselves to ask those questions is one way of helping us to not miss the more obscure diagnoses.
We often encourage patients to ask their health professional, what else could it be? And I suspect that sometimes doctors feel a little put off when the patient asks that question. How can we help patients communicate that to their doctors? I remember you wrote a book a few years ago. It was something about what patients say, what doctors hear. Can you tell us a little bit about that, please?
Yeah, I think there's an enormous communication gap that takes place in the exam room or at the bedside, which I think every patient and every doctor is aware of too. And a lot of it, again, does come down to the time crunch. And not that I want to blame all of our failings on that, but certainly if we had more time, so when a patient brings up a question, you think, oh my gosh, I'm going to fall behind. If I have to discuss this, I'm never going to get to the other 10 things I need to get to. So that's one of the reasons that doctors often get put off. But yes, sometimes, listen, we feel insulted that the patient is questioning our wise judgment. So one way I recommend for patients is to not be confrontational and just say, I'm just curious. Is there anything else that it could be? And in a low-keyed way that probably wouldn't, annoy someone. You're just curious. And anything else that, I want to make sure, what's the worst case scenario? And I think a good doctor should take that well and be relieved the patient's asking that. The other way is for the doctor to say to the patient, well, what do you think it is? I mean, what are you most afraid of? What are you most concerned about? And you might hear what's really on their mind. You might hear about, a family history of cancer you hadn't heard about before. And you might hear about just what their anxiety is about this, so you can be able to address that in real time.
You're listening to Dr. Danielle Ofri. She's a physician at Bellevue Hospital and a clinical professor of medicine at New York University School of Medicine. Dr. Ofri is editor-in-chief of the Bellevue Literary Review and author of several acclaimed books, including What Doctors Feel and Singular Intimacies, Becoming a Doctor at Bellevue. Her latest book is When We Do Harm, A Doctor Confronts Medical Error. Her writings, TED Talks, and monthly newsletter can be found at her website, danielleofri.com.
After the break, find out about communication breakdowns. They can be a big source of error in any arena, and healthcare is no different.
Are there ways patients can reduce their chance of experiencing a medical error?
Patient advocates may not be allowed to accompany you to the hospital in the middle of the pandemic. In normal times, though, it's good to take someone else along.
We'll find out how an overworked resident missed a lethal drug interaction.
We'll also find out when you should seek a second opinion.
You're listening to The People's Pharmacy with Joe and Terry Graydon. This People's Pharmacy podcast is brought to you in part by Verizana.com.
Verizana Lab offers home health tests that allow you to monitor your hormones and health conditions. You can take control of the quantitative assessment of your health and learn about male and female hormone balance, the stress hormone cortisol, leaky gut, gluten intolerance, or your gut microbiome.
Take a more active role in tracking your health and take 20% off your first order of a mail-in testing opportunity with the discount code PEOPLE. That's PEOPLE, all uppercase. To learn more, go to Verizana.com. That's Verizana.com. SANA.com. Welcome back to the People's Pharmacy. I'm Terry Graydon.
And I'm Joe Graydon. The People's Pharmacy is brought to you in part by Verizana, an analytical laboratory providing home health tests for hormones, gut health, and the microbiome. Online at verisana.com.
And by Kaya Biotics, probiotic products made in Germany from certified organic ingredients. KAYABiotics.com.
Today, we're talking about how patients and their families can improve communication with healthcare providers to reduce medical errors.
Have you ever played the children's game telephone? Children sitting in a circle whisper a message to a neighbor. When a message goes around the circle, it can bear no resemblance to the original statement. That sort of miscommunication can also occur in medicine when there are handoffs between healthcare professionals.
We're talking with Dr. Danielle Ofri. She is a physician at Bellevue Hospital and a clinical professor of medicine at New York University School of Medicine. Dr. Ofri is editor-in-chief of the Bellevue Literary Review. Her latest book is When We Do Harm, A Doctor Confronts Medical Error.
Dr. Ofri, communication is so important. While we were making supper one day recently, Joe was helping me by breaking the eggs and separating them. I was making a souffle. And he asked me, what do you want me to do with this extra egg yolk? Because there was an extra egg yolk. You use one more white than yolk. And I said, put it in that bowl, please. And I pointed. But the bowl that I had set out for him for the extra egg yolk was just on the other side of a bowl that had cheese in it to go into the souffle. So he assumed that I was pointing to the bowl with the cheese. Now, that was a very simple error. It was my error. It was his error. It didn't result in any damage whatsoever. But communication errors can. Are there ways that patients and doctors can use communication to reduce errors? We're thinking about a technique that we call teach back.
We do tell our medical students and residents about the teach back method. And so after we give a patient a set of instructions for the colonoscopy or how to take the medications, if we have time, we want to say, why don't you tell me what you understood of that? And often it can be quite different than what you thought you told them. Now, there can be a limitation if you're doing just one thing that works well, but that's pretty rare in medicine today. The patient's walking out with 6 medications or 10 and going for 3 tests. So in practice, it can be hard to do a teach back for all of that. But at least to pick, the most important one, okay, we're changing your Coumadin dose, which is an anticoagulant, that's, very narrowly prescribed. Let's go over how that is. And the same thing we give instructions to a nurse or a fellow doctor, especially if it's critical, to say, okay, tell me, let's go back over what we just said. Let me know that you know it. It's very important.
We would like to emphasize how important communication is and how important it is for patients to speak up if they see something that's making them uncomfortable. You talk about Jay throughout the book, and I wonder if you can help our listeners understand what happened to Jay. He was 39 years old. He'd been very healthy, and then all of a sudden he got a really bad diagnosis.
Yes, Jay was a very healthy young man who got a very rare form of leukemia. And the reason I profiled Jay is that his wife, Tara, is a nurse and an emergency room nurse who's worked in CCUs and critical care areas. So she's quite knowledgeable. And I wanted someone who already knew both sides of the coin. And so in his medical care, and it's a very extensive case, many things happened. And she tried to speak up, even as a member of the profession, and it was hard to get heard. The medical team, I think, took umbrage at her comments, thought she was butting in or being critical of them. And she could not make herself heard when things began to go wrong. And she had to live with this terrible guilt, thinking that she wasn't able to help him in his moment of need. And so if someone who's a nurse, an experienced medical professional, finds it hard to speak up, imagine what it's like for people who aren't in medicine, and it's extremely hard to buck, the system and be the squeaky wheel.
Oh, I think it's very, very hard. There are perhaps things that people can do and should do to reduce the chance, reduce the likelihood that there will be a serious error made in their case. You have a list. Can you tell us about some of those things?
Well, some of them are very simple. So one is to have a clear understanding of your own medical history. And it sounds so simple, but a lot of patients don't know the details. And you could, at some point when things are not urgent, have either your doctor or nurse or family member help you make a one-page list of your medical conditions, what medications you're on, and what allergies you have. Those are the key things. So when you end up in the hospital or at a doctor's appointment, you can give a concise summary and don't bring in the 50 pages, footnoted history, but a concise summary. So knowing that. The second is when you're getting medications or a treatment, ask what they are and write them down, or have someone write them for you, just to know what each medication is. Make sure you know your allergies and ask why you're getting them. At the very least, you're owed that explanation. And then if you're in the hospital, if you or your family member can keep a notebook of just what's happening each day, what tests are happening, what are the results, you have at least a timeline so you can ask questions. I mean, all the information, it's yours. You own it. And maybe your nurses and doctors are so busy and they don't feel like taking the time, but you really own that information. And a patient advocate in a hospital or in a medical center can be very helpful for you in getting the information that you need.
Well, in the time of COVID, of course, patient advocates are probably not available. You can't have family members in the hospital with you. But in a normal time, very often it's a great idea to have someone go with you or be there during the doctor's rounds to be able to take notes. If the patient's really sick, they'll find it difficult to take notes or remember everything.
Sure. And even in COVID time, someone can be there by phone. The patient advocate, the family member, we are trying very hard using FaceTime and phone technology because it is critical to have someone there with you. And if not in person, they can, maybe your spouse can't come to your doctor's appointment, but they can call in for those 15 minutes and listen in.
Dr. Ofri, we understand that your PhD is in pharmacology, and as a pharmacologist, I'm particularly interested in side effects, how patients are warned, what are the most common or what are the most serious side effects that might lead to something really, really bad happening. We all see on television the commercials for prescription drugs, and it's not uncommon for this long list to be rattled off while people are having just about the most fun you can imagine. And somewhere in that list are things like heart attacks, kidney failure, and death. And so, patients, I think, begin to ignore what seems like a really serious list of side effects because, hey, people are having fun. I don't need to worry about that. How can doctors and patients communicate effectively about adverse drug reactions?
Well, doctors have the same issue. For every medication, there is that list of 1,000 things. And if I were to go through that list for every medication, it would take me all day with one patient. So we can't do that either. The critical thing is to be aware of the common effects or the serious ones and to weigh the risks and benefits of each medication or test. So, for example, there are medications like Coumadin, as I mentioned, the blood thinner, that have very serious side effects. But in a case where the benefit is very strong, it might be worth it. But the same medication in a condition where the benefits aren't that strong, then the side effects in essence weigh more heavily. So it matters what the circumstance is. And we always need a context for that. As a patient, you can ask just what are the main side effects? Because that whole list, you can look it up too, but you'll be defeated in 10 seconds because there's just too much to read. And partly, the drug company is required to list every possible side effect ever reported. Even if it's not caused by the medication, if a patient taking it reported it, it has to go on that list. So it's very hard to know which ones are really real. So we try to use the most common ones.
There's another aspect for drugs as well, and it's not just an individual drug side effects, but drugs can interact. You do have a story in the book about a famous case, the case of Libby Zion, a teenager who showed up at a New York hospital. Can you tell us a bit more about what happened? What went wrong with Libby Zion?
Well, it's a very famous case with many things that tragically went wrong, of this young woman who came into the hospital, and she was very agitated and ended up being sedated and got medications to calm her down, which interacted with the medication she was taking, and she ultimately died. And part of what came to light in the case is that the doctors taking care of her were so overburdened. They were taking care of 30 or 40 patients each, that they couldn't possibly give the attention that was needed on the case. And so her case became a turning point for instituting work hour regulations for doctors in training. But it did highlight the issue of medication interaction. We often aren't aware of what patients are taking, or even if we are aware, we may not know all the most important interactions to watch out for.
Well, I have a personal story to share with you, Dr. Ofri, because my mother died at one of the best hospitals in this country as a result of a drug interaction, and it involved the same drug that Libby Zion was taking, Demerol, a pain reliever, which is an opioid, a narcotic. And throughout her chart, it said no opioids because my mom couldn't tolerate them. And she was 92 at the time. She'd had angioplasty. For a woman her age, she had great coronary arteries, but one that was about 30% occluded. These days, of course, they never would have done the angioplasty and the stent, but in those days, they were still thinking that was a good thing to do. But here's what happened. At 10 p.m. that night, a resident came by following a protocol and injected into her line, her IV line, Demerol and Phenergan because they wanted to keep her sedated after having, had this angioplasty. Well, she developed something called serotonin syndrome, very much like Libby Zion, and bled to death the next morning. So mistakes can happen, and I still feel guilty that I somehow wasn't able to prevent that terrible medical mistake.
It's such a tragedy because they do happen. I mean, we hope in the age of the electronic medical record that the very big contraindications will come up, in big bold red letters to make that not happen. But even with electronic medical records, it's tragically can still sometimes happen.
And of course, this actually did happen before the age of electronic medical records. The doctors were not aware that she was also on Eldepril, which would interact with those drugs to cause serotonin syndrome.
Dr. Ofri, there are a lot of what we call electronic aids these days for all sorts of things that we do. And I know that a lot of patients are now using Dr. Google is supposed to be able to help us diagnose. There are also programs. There's one called Isabel. How helpful are those electronic devices or databases that allow patients to put their symptoms in and get we'll call it a differential diagnosis, a kind of a preliminary possibility of what could be going wrong?
It's a great question. We don't really know because it's very hard to study, and the data have been limited, and also the data are mainly have been studied mainly by the people who make these commercial products. So there could be some bias in there. In the times that I've used it, certainly in the generating a differential diagnosis, I found it of mixed help. It certainly brings up some of the rare things I might not have thought of, but I found that it was a little cumbersome for so many of the obvious things that I already know are not the case because I'm seeing the patient. I know they're not having a ruptured aortic aneurysm because they're chatting with me in the office. So it misses the gestalt of the patient. However, there are many aspects of artificial intelligence that can be helpful, particularly in areas where maybe resources are limited. So if you imagine a country that in a developing country that doesn't have a lot of radiologists, that having an AI program that could read chest x-rays quickly and give at least preliminary diagnosis could be extremely helpful. Or programs that can help do screening eye exams for diabetics. So I think there are roles for that. And we still need the experts for the difficult cases, but we could really use them for a lot of the general cases where we don't have the resources.
When should a patient seek a second opinion?
I think we should seek second opinions more than we currently do. Certainly for serious diagnoses with treatments that have high risk. So when you're about to get chemotherapy for cancer or considering a heart transplant, those are things that are certainly worthy of a second opinion. If it's about your reflux disease, you could do it if you want, but the truth is, no matter which medication you take, it'll probably get better, in a little bit on its own. So I would reserve that for complex cases, but I think we shouldn't be afraid to do that. And I also think that doctors shouldn't be afraid to ask for second opinions as well, to question their own judgment, to get another opinion on the choice of treatment.
Dr. Danielle Ofri, you've written When We Do Harm, A Doctor Confronts Medical Error. It's a fabulous book. What are you hoping your readers will take away?
I hope that the readers will start to understand that medical error is much more complex and subtle than we think of it. We tend to think of these, courtroom dramas on cable TV, but that's really such a tiny aspect of it. And the idea of patient safety as a more global issue, and that if we try to go with this sort of fancy, slogan of, well, just get rid of all medical error, we'll have, like we have with the checklist, kind of just people kind of making it go away. What we really want to do is try and just make it overall safer for everyone in the healthcare system, because we're all patients, and we all go into the hospital or the doctor expecting to be at least better off and not made worse by the treatment. I think that's a fair statement. And so that we have to think about more of the subtle issues of how we can make the healthcare system safer for everyone.
Dr. Danielle Ofri, thank you so much for talking with us on the People's Pharmacy today. And we want to thank you and all of your medical colleagues, the nurses, the doctors, the nurse practitioners, the PAs, everyone who is working so hard to save lives during this COVID-19 epidemic.
Thank you. It's truly a group team effort. It's really incredible to see.
You've been listening to Dr. Danielle Ofri. She's a physician at Bellevue Hospital and a clinical professor of medicine at NYU School of Medicine. Dr. Ofri is editor-in-chief of the Bellevue Literary Review and author of several acclaimed books. Her latest work is When We Do Harm, A Doctor Confronts Medical Error. Dr. Ofri is a regular contributor to the New York Times. Her writings, TED Talks, and monthly newsletter can be found at danielleofri.com and on Twitter at Danielle Ofri, O-F-R-I.
Lynn Siegel produced today's show. Al Wodarski engineered. Dave Graydon edits our interviews.
The People's Pharmacy is produced at the studios of North Carolina Public Radio, WUNC. This week, the show is recorded in our home studio.
The People's Pharmacy theme music is by B.J. Liederman.
The People's Pharmacy is brought to you in part by Kaya Biotics, probiotic products made in Germany from certified organic ingredients. KAYABiotics.com.
To buy a CD of today's show or any other People's Pharmacy broadcast, you can call 800-732-2334. Today's show is number 1209. That number again, 800-732-2334, online at peoplespharmacy.com.
And when you visit the site, you can share your thoughts about today's show, sign up for our free online newsletter, or subscribe to the free podcast of the show. Never miss another episode.
In Durham, North Carolina, I'm Joe Graydon.
And I'm Terry Graydon. Thank you for listening. Please join us again next week. Thank you for listening to the People's Pharmacy Podcast. It's an honor and a pleasure to bring you our award-winning program week in and week out. But producing and distributing this show as a free podcast takes time and costs money.
If you like what we do and you'd like to help us continue to produce high-quality, independent healthcare journalism, please consider chipping in.
All you have to do is go to peoplespharmacy.com/donate.
Whether it's just one time or a monthly donation, you can be part of the team that makes this show possible. Thank you for your continued loyalty and support. We couldn't make our show without you.